Hey everyone, I'm Harrison Hall from Station 63, and today we're going to talk about something that is critical for all of us in the fire service, and that is the importance of thoroughly and accurately completing our call reports, specifically the ePCRs. For us, every detail matters, and it's not just how we respond to the call and what we do when we get there. It's about ensuring that we provide the best care possible. And a big part of that comes down to how we report and document our actions. Now, through our quality control process here at the department, we've noticed that there have been a few issues specifically revolving around narratives on major medical calls that we want to try to address and brush up our skills on how to use fireworks to the best of its abilities. When our ePCRs are filled out correctly, they provide immense amounts of data for our agency and EMS to improve services, but they also have real tangible impacts on that patient's life. I know you may be saying, why does this matter this much? Well, it's simple. Throughout the continuity of care, patient care reports from the field all the way through the hospitals are a cornerstone. I get that these reports can be frustrating, but they ensure that the appropriate care is being given and they provide essential legal protection for yourself, your crew, and the department. But perhaps most importantly, they are a tool for us to learn from and grow with experience. Throughout this session, we're going to be examining some real world examples where the lack of detailed patient care reporting had significant consequences. And these aren't just hypotheticals, these are real lessons that other agencies and providers have learned. We're going to take a deep dive into fireworks, and I'm going to help guide you through some of its features and demonstrate how to fully utilize the reporting software. This tool is powerful if we use it correctly. So let's learn together, not just for our sake, but for the people who count on us every day. Thank you for being here, and let's get started. So let's start talking about ePCRs here in fireworks. I have already completed a patient care report, and all I did was what the report required of me. So this doesn't give us much information. It gives us an age, a location, a dispatched complaint, but there's not too much more after that. It gives an impression of a cardiac arrest, and other than that, it's about it. It gives plenty of open spaces that prompt an answer, but they're blank. This is what the auto-generated narrative provides if you just simply go and only do the minimums on ePCRs. There's a major issue with this, especially on big medical calls where a lot of skills, procedures, and assessments have been done. If they're not documented, they never happened. Many court cases are not litigated in a courtroom until 3 to 6 years after the incident occurred. Therefore, whenever you have such a minimalistic narrative, it's going to be next to impossible to remember the small details that you need to that long down the road, especially in a courtroom with attorneys throwing questions at you in that stressful environment. But if we take our time to do a detailed patient care report by just spending an extra few minutes clicking some more buttons, we go from a 1,500 character count auto-generated narrative to over 6,600 characters. That's a lot more information by just taking an extra 5 minutes to click some buttons. So here's a new ePCR. Let's talk about some of the highlights to get that better auto-generated narrative to come up. Of course, with patient info, you put in as much demographics as you can, name, date of birth, and so on. And then from there, we can go into medical history. This is getting skipped a lot, and it's got a ton of really good information in there. This doesn't have to be exact, but it's just an estimation that's going to provide a more detailed view of what this patient looked like once it gets translated into just words. Let's say that a family member had to leave the scene to take kids away or whatnot during this code. Well, we were the only ones who heard them say that the patient had AFib. So we need to make sure that we get AFib put in there because it's really easy for that small little tidbit to not get translated down the road. Now, if this person's from out of town or they've never had contact with EMS or even the hospitals before, they may not have their medical information there. So the county has access to be able to come straight into our ePCRs without having to ask for permission. And they can get this information, especially whenever it's been a couple days and the physicians are saying that something's not really adding up right. Maybe we have in a good ePCR the information that they need. We're able to notate if there was any barriers to patient care or if there are any medication allergies. If there's not, you just click the button to the side and you're able to put no known drug allergies. Now, if we're doing something where we're actually giving medication, we need to make sure that they're not allergic to something. So with that being said, notating with that one little bubble check mark says that we have done that and we've documented it. Any current medications can be put here. And finally, there's alcohol and drug use indicators. These are great to be able to put on here and how you think that this person may have been under the influence in one way or another. So let's move on into the biggest piece, which is going to be assessment. So here we're going to start off with the chief complaint. We've got our time of the symptom onsets, which could easily be the time of the 911 call. This cardiac arrest patient's primary symptom was not breathing, so respiratory arrest, and our primary impression was cardiac arrest. If there's anything else associated with this, they can be notated here. Now, the patient's chief complaint would be cardiac arrest. Over here in the cardiac arrest section, we click the applicable button. So yes, prior to EMS arrival. And this is an important thing to note. For this ePCR, whenever you see EMS, we're referring to the fire department. That's how this program's written. That really means yes, prior to fire department arrival, but it's written as EMS. So that's a good perspective to have when you're filling these out. There's information about strokes, possible injuries. We're going to go to vital signs. Now, vital signs for many calls, if you have a conscious patient and a lot of objective data to put in, then you can just click add new and start doing that. All right, so for this vital signs section here, we're going to start by adding a new one. And for our cardiac arrest, these can be pretty simple to put in. We can click quick NV here. So for cardiac arrest, exam finding not present. So no blood pressure, no heart rate, no respiratory rate. You'll see that after we click those buttons, we come down here to blood pressure and this is blue. So that means exam finding not present. Same thing with heart rate. Anything else that you took during this CPR, you can notate. If you did multiple rounds of vital signs, especially if there was some type of ROSC before Guilford EMS arrives, you can do multiple vital signs sections to be able to notate that. So now that we're here in the exam section, we need to notate what we saw about the patient. So here in the exam section, we need to notate what we saw on the patient or about the patient. So if we add a new one here, we're able to have the time that we were at the patient. And then we can begin with doing a quick assessment. So from here, we can either say normal, not done, or comment. If we click normal here at the top, it's going to highlight all of these as green. Or if we did not done, it would be the same. All you have to do is put the facts in here. So if we notice that the skin was cyanotic, we can notate that here. But if there was no trauma to the head, no trauma to the face, but over here on the eyes, they were non-reactive, we can type that there, and so on. Or the other way that we can do this is we can come through and we can say here with the eyes that they were non-reactive. If this is a major trauma call, this is a great area because you're able to notate all of the individual wounds and injuries that you saw on the patient right here in an easy to use format that's going to break the body down into different parts. Now that we're done with the exam, let's take a look at procedures. So here in this version, we have a adult cardiac arrest. This is going to lay out all of our procedures. So it starts off with our assessment, which is going to be the exam that we just filled out. From here, we can put the crew member who completed that. And if there are any complications to anything, we're able to put this through here. Then next, we have the procedures listed out of defibrillation, airway, CPR that was manual CPR, assisted ventilations, and the insertion of an airway device. If you're going to use the auto-generated feature, these are critical. These need to be put in there so that way whenever you click auto-generate, it's notating everything that you did. Now you do need to be careful and make sure that you're paying attention to the times, as they can get a little weird when it comes to the system generating it. If there's an issue with keeping up with accurate times, I like to make sure that I put in my narrative that these times are estimates due to everything that was going on at the call. So once you're happy and you have all the procedures that you used put in there and filled out, then we can go on to the next one, which is going to be the medications that we administered. So now that we're in our medications, we need to remember that oxygen is a medication. So we can bring up oxygen. It's got our type of medication, our route. You can put in the dosage, which we could say would be 12 or maybe 15 liters per minute. If there were any complications, you can put that here. And then if you began using this oxygen and the patient's O2 saturations were in the 80s and then all of a sudden they're in the 90s, then you could click improved. And then finally, we can go over to injury. So this is a great area to be filled out if you have someone who is a trauma patient. You're able to get more detailed into actually how this trauma occurred. This isn't that much different than filling out a NIFRS report for a structure fire. It's the same type of breakdown. It just doesn't have to do with fire. It has to do with the patient. Finally, we have the invasive airway section, which gives us the indications for the invasive airway, which would be our apnea or agonal respirations, if there were any complications that may have occurred, and then any reasons for why the airway management may have failed. It could be because the patient's anatomy was unique, or if there was trauma, or perhaps patient access or fluids in the upper airway. So if we inserted a blind airway device, we need to notate that it was confirmed as being appropriately placed. So here we just click Add New, and then from there we go to the airway device being confirmed. This one doesn't yet have the iGels on it, so I'm just going to click King, the person who confirmed it, and then how they did that. So if they were listening to lung sounds, we can click this, and then if there was condensation in the tube, then we can do that as well. And then we go here to our procedures, and we're going to link it to the insertion of the airway device. So finally, the last tab is going to be the cardiac arrest tab. And from here, we need to fill out all of this. So it's going to be the date of the call, who it was witnessed by, if we are just presuming that this person had a cardiac issue and then they coded, or if it was because of narcotics or drowning. Resuscitation attempted by EMS, remember, that's us. So we attempted defibrillation, ventilation, we did chest compressions. Or if there was a DNR, or the date of our initial CPR, and then our CPR time that communications recorded, or our at patient time. And then if there was any CPR care provided prior to our arrival as the fire department. Many times that's going to be yes because of a family member doing it with 911 instructions. Then when it comes to first monitored arrest rhythm, we're not monitoring them ourselves, but the AED is. So let's say that the AED found a shockable rhythm. Was there any ROSC? So now that we're done with filling out our patient and assessment sections, we're going to look at disposition. This one's real quick to where we're just going to put patient treated and then transferred care to EMS. So this is going to mean that we gave them over to Guilford County EMS, or if it was PTAR or someone else. Okay, so now here we are in our narrative section. So let's do that auto generate. So if you remember, our first one with just the minimums filled out was about 1,500 characters. After we've taken our time to fill out everything else, we're at over 5,500. Now you're able to see and prove everything that you did for that patient. So what I like to do is make sure that I put in my own words anything that this auto generation is not going to cover. Now, for a CPR, yes, this is going to take some time. There's a lot of data that you need to fill out. But for your run-of-the-mill medical call, there's not that many boxes to check. It's not going to take that much extra time. Just make sure that you're being able to get in any of the medications like oxygen that you use, medical history, and be able to put in one of those assessments to be able to prove how you examined that patient and what your indications for treatment were. Whenever I'm writing my part of a ePCR narrative, I like to use a list of questions that all I have to do is type out my answer to, and that provides a more than adequate narrative of the call. These questions came from a study that was done at a Midwest fire department that was a municipal department similar to ours that had recently run into some legal issues involving how they documented their ePCRs and how they were able to prove effective in their standard of care. So the first question that I look at and answer is, consider the scene dynamics that influenced your decision making and primary/secondary impressions. What did you observe upon arriving at the scene and to the patient? The next question is, what interventions did you provide and why? So you could easily answer that question by saying, see the interventions listed below due to the fact that the patient was not breathing and did not have a pulse. The next question is, what were the results of those interventions? The fourth question is, was there a deviation from patient care protocols? If yes, explain your clinical decision making. And if there were no deviations, you can simply ignore the question and keep moving to the final one, which is, if there is anything else you would like to add about the response, please include it. Just to finish out this lesson, there was a case in 2005, Hensley versus the Provena hospitals. There was a call for service where a woman, Shirley Johnson, was coding, going downhill fast, and by the time EMS got there, she was agonal. The documentation from that PCR failed to describe how Miss Johnson's airway was handled, and subsequently Miss Johnson died after a battle with brain damage from hypoxia. Several years later, as this case was litigated in court, due to the lack of documentation, it was found that the EMS agency and those particular providers were held liable for gross negligence, simply due to the fact that their care was not appropriately documented. There was another case out of Jersey City where EMS and fire was called for a patient who was a victim of assault. On the way to a local non-trauma center hospital, the patient vomited. That one act was not documented in the PCR. Subsequently, the patient was discharged, and another call for service was placed shortly thereafter, where EMS and fire responded once again. This time, the patient was having a seizure. They took him to a trauma center where he fell into a coma and later died. The lawsuit that came out of this was foundational due to the fact that it separated negligence between the actual act of caring for a patient and documentation. So the courts found that had EMS documented and were able to prove that they provided that information to the receiving hospital, that patient would have never been discharged and that level of care would have never been stopped. But because they failed to document and prove that they did that, they found that their documentation was negligent and Jersey City was held liable for the death of this assault victim. I know that this information can be dry, but it is very important, not just for the department's safety whenever it comes to documentation, but for everyone who works here, including those that you work closely with every day on your crews. Whenever you're filling out these PCRs, you are documenting what someone did. So they may have no clue that a document was not filled out appropriately whenever they are being called to a witness stand years later. So, if you have any questions, please let us know. Have a good one. Stay safe.